kesehatan jiwa. PDS KJI milik bersama, saling berbagi pada sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbakti, mengabdi pada Ibu Pertiwi. jiwa. PDS KJI milik bersama, saling berbagi pada sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbagi, mengabdi pada Ibu Pertiwi. negara, bersatu berjuang untuk meningkatkan derajat kesehatan jiwa. PDS KJI milik bersama, saling berbagi pada sesama, berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbakti, mengabdi pada Ibu Pertiwi. jiwa. PDS KJI milik bersama, saling berbagi pada sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbagi, mengabdi pada ibu pertiwi.
Okay, good evening, ladies and gentlemen. The Honorable Dean of Faculty of Medicine, Widya Mandala Catholic University Surabaya, Professor Dr. Medicine, Paul L. Tahalele, Doctor Specialization in Cardiothoracic and Vascular Surgery, Consultant in Vascular and Endovascular Surgery. The Honorable Speaker today, Dr. Benjamin Kasenda, Ph.D. from Switzerland. Distinguished Vice Dean of the Faculty of Medicine, Widya Mandala Catholic University Surabaya, Dr. Hanti Suyono, Master in Medicine, Dr. Gwedi Bawoluntu, Master in Science, and Dr. Stephen, Master in Tropical Medicine. The Honorable Head of PHC Teaching Hospital Surabaya, Dr. Puji Januartono, and all respected professors, doctors, educators, and all students participating in the essential learning this afternoon. Let me introduce myself. I am Dr. Wilson, who will guide the course of this event today. I would like to invite the audience on cam for more interesting and interactive session. Ladies and gentlemen, today Dr. Benjamin Kasenda will bring essential learning about updates in the diagnosis and management in hemato-oncology. First of all, before we start, allow me to open this event in a Christian prayer. All respected participants are welcome to pray according to their own respective religions and beliefs. Attendants are asked to take a prayer stance. Dear Heavenly Father, we give thanks for your blessing you have bestowed upon us up to this point. Thank you, Lord, because today we can all gather virtually to take a part of Essential Learning with Dr. Benjamin Kasenda today. We ask for your support, Father, so that the series of the event can be held, carried out well and smoothly. Thank you, Father. We put everything into your hand. Amen. Step on the following agenda, I would like to invite all of you to sing our national anthem, Indonesia Raya, and followed by our faculty march together. Please adopt a perfect attitude.
Indonesia, tanah airku, tanah tumpah darahku. Di sanalah aku berdiri, jadi pandu ibuku. Indonesia, kebangsaanku, bangsa dan tanah airku. Marilah kita bersatu, Indonesia bersatu. Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah padanya untuk Indonesia Raya. Merdeka, merdeka, tanahku, negeriku yang ku cinta. Indonesia Raya, merdeka, merdeka, hiduplah Indonesia Raya. Fakultas Kedokteran Widya Mandala Uns College Medicinos, majulah terus Pancasila dalam hidupku kita amalkan untuk sesama kita, untuk nusa dan bangsa. Dokter profesional berspiritualitas, berintegritas moral, berdisiplin, soft skill prima, belajar bersinambung dengan etika dan sopan santun. Kami layani sesama. Fakultas Kedokteran Unika Widya Mandala. Fakultas Kedokteran Unika Widya Mandala.
Okay, before we step into the next session, I would like to invite the Dean of the Faculty of Medicine, Widya Mandala Catholic University Surabaya, Professor Dr. Medicine Paul L. Tahalele, Doctor Specialization in Cardiothoracic and Vascular Surgery, Consultant in Vascular and Endovascular. Please, Professor Paul.
Thank you, Dr. Wilson, as host of this event. Good days, good afternoon, all of the participants. And Today we have a special guest lecture from Switzerland, from Basel University, Dr. Benjamin Kasenda. How are you, Dr. Benjamin Kasenda? I hope you are still healthy and happiness. And last week we have chat via telephone, and of course, I only 4 days in Geneva to attend the meeting of the WHO, World Health Assembly 75th. And you know that's in very busy time, I disturb you. Sorry. Dr. Benjamin Kasenda is a lecturer at the university, Basel University, and he's a expert in oncology, hematology oncology. I hope and your lecture to our medical student can give they a lot. They can learn a lot of your lecture. And thank you very much. This lecture actually to increase our medical student knowledge and open-minded. Yeah. The horizon, what's it's happened in the medicine in the abroad, especially in the industrial country. And thank you very much for your time and your willingness to give this lecture. Once again, I hope it's all you can learn from your lecture. And God bless you and God bless us.
Okay, thank you very much, Professor Paul. Furthermore, there will be a second remarks from the head of the Ph.D. Primary Teaching Hospital. Please welcome Dr. Puji Januartono.
Thank you, Dr. Wilson. Oke, mohon maaf saya pakai bahasa Indonesia. Selamat petang. Mohon maaf, ini saya perjalanan di Pulau Madura dalam rangka pengembangan pelayanan di Rumah Sakit Ph.D. Buat Prof. Paul dan teman-teman dekanat, saya sangat apresiasi atas terselenggaranya acara seperti ini. Ini yang ketiga kali, luar biasa Prof. Dan teman-teman semua. Kami dari Rumah Sakit Ph.D. support full untuk kegiatan seperti ini dan nanti dalam pengembangan ilmu di Rumah Sakit Ph.D. Luar biasa buat adik-adik saya, para mahasiswa, kesempatan yang sangat-sangat berharga ini mudah-mudahan bisa dimanfaatkan dengan sebaik-baiknya. Karena akan membuka wawasan kita bahwa di pembicara-pembicara dari luar negeri ini betul-betul yang berkualitas sehingga ke depan kemajuan ilmu kesehatan atau ilmu kedokteran akan sangat bisa kita raih bersama-sama. Kemudian yang kedua buat Dr. Benjamin Kasenda, terima kasih atas nantinya untuk sharing ilmunya sehingga teman-teman yang ada di FKWM ini bisa menerima dengan baik dan untuk pengembangan keilmuan selanjutnya. Sekali lagi apresiasi yang sebesar-besarnya, mudah-mudahan Tuhan Yang Maha Esa memudahkan dan melindungi dan meridhoi apa yang kita kerjakan di sore hari ini. Terima kasih, mohon maaf, selamat berwebinar, dan selamat sore. Terima kasih.
Terima kasih Pak Puji.
Thank you very much, Dr. Puji Januartono. Okay, before we listen to the essential learning, allow me to introduce and read the CVs of our moderator today. Please. Our moderator today is Dr. Irene Lincoln Parangkuan, specialization in anatomical pathologies. Now in Department of Pathology, Widya Mandala Catholic University Surabaya, and as an anatomical pathologist at Gotong Royong Hospital and Mitra Keluarga Hospital Surabaya. Next. Dr. Iren Education is take a medical doctor degree from Samratulangi University, Manado from 2003 until 2009. And then her anatomical pathologist degree from Airlangga University, Surabaya from 2015 until 2019. And her membership is be a member at Ikatan Dokter Indonesia and Indonesian Association of Pathologists, and in Surabaya section as an officer. Okay, that's all from the Dr. Iren CVs. And now I will give to Dr. Iren as moderator today. Please, Dr. Iren, time is yours.
Okay, thank you very much, Dr. Wilson, for a kind introduction. So good afternoon, everyone. Thanks for joining us in this session, the fourth series, I guess, from Essential Learning. And I'm Irene Parengkuan from Widya Mandala Surabaya Catholic University. This afternoon, we are very pleased to have Dr. Benjamin Kasenda as our guest lecturer. And as a brief introduction, IT team, could you please help me to share Dr. Kasenda CV? Okay, thank you. Dr. Benjamin Kasenda is a senior consultant medical oncologist from Department of Medical Oncology, University Hospital Basel, Switzerland. Next. He has many years of experience in hematology, oncology, and also medical oncology, and also genuinely passionate about research. Here we can see at 2008 until 2010, he was a specialist registrar in hematology oncology, Freiburg University Medical Center, Germany, and 2010 until 13 as clinical researcher at Basel Institute for Clinical Epidemiology and Biostatistics at Basel. 2013 until 2014, he was a specialist registrar in medical oncology, also at University Hospital Basel, Switzerland. And 2014 until 2019, he was associated senior clinical researcher at Klinikum Stuttgart in Germany, while he was doing the fellowship in clinical research under mentorship of Professor Martin Gore in renal and melanoma unit, followed by Professor David Cunningham in GI and lymphoma unit, both in the Royal Marsden Hospital, United Kingdom. Next. 2016 until 2018, he was a senior clinical researcher in Basel Institute for Clinical Epidemiology and Biostatistics. 2016 until 2017, specialist registrar in medical oncology, University Hospital Basel. 2017 until 2019, he was a consultant medical oncologist from Department of Medical Oncology, University Hospital Basel, including joint appointment by the Department of Medical Oncology and Department of Hematology. And in 2019, he was a consultant medical oncologist and the lead of the clinical studies and cancer epidemiology at Stuttgart Cancer Center or Cancer Center Eva Meyer-Still in Klinikum Stuttgart, Germany. 2020 and until 2021, he was a director of research and development, IO Medico at Freiburg, Germany. And since 2021, he was a senior consultant medical oncologist at University Hospital Basel, Switzerland. And also, Dr. Kasenda qualifications, he got the license to practice medicine at 2008, and then got the Ph.D. degree at 2014, and also got the board certification of medical oncologist in Switzerland at 2017, and also obtained the habilitation in experimental medicine at University of Basel at 2017. He's also very keen on teaching, as you can see here, since 2012. He is giving regular tutorials and lectures for medical students at University of Basel. And since 2018, he is doing a supervision of postgraduate clinical research fellows and also for medical MSc students at University Hospital Basel. And since 2019, he is a regular lecturer. He's giving a regular lectures for medical students at ETH Zurich. And since 2022, he's in charge of teaching scientific methods. He is also very active as member of some professional association or study groups. Here we can see some of them. And for the next 30 minutes, Dr. Kasenda is going to talk about the updates in hematology oncology, focusing on lymphoma. Yeah, the overview of diagnostic, management, and outcome. And then after the lecture, we are going to have about 40 to 45 minutes for discussions. So for everyone, anyone who have question, you can type down your question on the chat room, or maybe later on you can discuss directly with Dr. Kasenda. Dr. Kasenda, once again, thank you very much for taking time out your busy schedules to share your knowledge and experience. Yeah, looking forward for your talk. Without further ado, Dr. Kasenda, the time is yours.
Terima kasih. Thank you very much. Yeah, so when I was approached to give that talk, first I didn't know what to do, but then I learned more about the university and the audience, and I hope that the next 30 minutes, 40 minutes, I can give you some insights on hematology. It will be focused on lymphoma, because hematology is a very, very big field, but I think I can give you some insights. What is currently going on? What is the standard of care? And where should we go in the future? And just probably for the background, because that's not in the CV, I'm half Chinese Indonesian. So my father, he's from Tasikmalaya in Java. I've been many times to Indonesia. I've never been to Surabaya so far, but I understand a bit of Bahasa Indonesia, but only superficially. So it's better when we do it in English, the whole talk. All right, so I share my screen. Here we go. So I changed the title just slightly, but in the end, it gives the same content. So it's the heterogeneous landscape of malignant lymphomas, an overview on diagnostics, treatment, and outcome. And I've chosen a very practical approach, because I think this is what sticks best in our heads, and then we have a good ground for discussions later. So first of all, if we're talking about lymphoma, it's a question, what is a lymphoma? When I was a medical student, I was overwhelmed. I couldn't understand it. What is a lymphoma now? Is it just a swelling of the lymph glands? I mean, this is lymphoma. And then when I started reading a bit the medical textbooks, I said, okay, there's Hodgkin lymphoma, there's non-Hodgkin lymphoma, there's B-cell lymphoma, there's T-cell lymphoma, there's aggressive lymphoma, there's indolent lymphoma. And still today, when junior doctors come to our medical department, they say, okay, I understand what a colon cancer is, but what is a lymphoma? And in fact, that's not easy, because it's a very, very heterogeneous group of diseases. And I hope that I can give you some of these classification and the way we think about lymphomas by that talk. So first, we start with a clinical case. So you sit in your clinic and there is a 19-year-old male patient coming to you in an outpatient clinic. He's not on a ward. He's not very sick, but he has been sent because he has swelling on the neck since about 3 weeks, and he reports night sweat. So he's not, and he's feeling tired. And usually, he's going to university, but now he's not feeling so good. So that's why he comes to the office. And of course, we're talking about lymphomas here. So, I mean, there could be many other differential diagnoses. You could have an infection This is the most likely thing when you have swelling of the lymph glands, that it's just a reactive swelling of the lymph glands and no malignant background. But night sweats is usually not associated with common infections. Of course, you can have night sweats when you have, for example, tuberculosis, or you have really a strong influenza, but otherwise he's healthy. So it all sounds a bit odd. And what we do usually is then, of course, we do a clinical examination. We look, okay, how is the patient looking? We listen at the chest. We try to palpate the lymph glands. We investigate the liver and the spleen. And of course, when there's suspicion for lymphoma, you also look for the virus serology. So we check for hepatitis, we check for HIV. We also check for CMV, so cytomegalovirus, and Epstein-Barr viral infection, EBV. And when the clinical examination together with a blood test, it really gives you suspicion for lymphoma, we do imaging, of course. So we try to find out, okay, is there lymphoma? Can we see it in the body? And the current standard of care is to at least do a computer tomography, CT scan. However, if that's not available, you can also do ultrasound. You can ultrasound do of the neck and the abdominal cavity. And if you want to investigate the chest, you can do a chest X-ray. So that is like what we did before, but now it's the standard to do at least a CT. And at best, you do a positron emission tomography, a PET-CT. So that's a nuclear medicine investigation, because this is the most sensitive way to detect a lymphoma. Not for all lymphomas, but especially for the most common types of lymphomas, the PET-CT is the standard of care. Very interestingly, PET-CT in Germany, a rich country, it is not necessarily paid by the health insurer. It's not reimbursed because they say a CT should be enough. But if you look at the international guidelines, if you would be a patient in the United Kingdom or in Switzerland, they give you a PET-CT. So even in these developed countries, there are disagreements of what should be paid and not. So imaging is important. And the other thing, of course, is biopsy. So if you redo the imaging and you see something, you say, okay, I want to be sure, what is it? And we need to biopsy it. And this is the most important take-home message from that slide. If you have suspicion for lymphoma, you need to resect the lymphoma for diagnostic reasons, or you should at least aim for it. So for example, if you have swelling on the neck, you should send them to the ENT department or whoever does diagnostic lymph node resection. It's not for taking out the tumor to cure the lymphoma. No, it's for diagnostic reasons. If that's not possible, for example, if you have a suspicious lymphoma in the abdominal cavity and you don't want to do a laparotomy, then you could ask your interventional radiologist to biopsy the lymphoma or the suspicious lesion with a core needle. Yeah. But don't do fine needle aspiration, because with fine needle aspiration, based on the current standards of diagnostics, you will not reliably diagnose or exclude lymphoma. There are situations where you don't have other choices, yeah, but whenever possible and clinically possible, you should try to get a diagnostic lymph node resection. Maybe also from the axilla, maybe from the groin, you know, wherever you have the suspicious lesion. So now a patient, what happened? So we did a blood test, so there was no hepatitis, no HIV infection, and he has a really enlarged cervical mass here on the right side. We did a PET-CT, and that showed also mediastinal involvement and retroperitoneal involvement. So we have involvement on both sides of the diaphragm. So this is at least stage 3. You probably remember there is the Ann Arbor classification saying, okay, when it's really located to one lymph node area, then it is a stage 1. If you have more than one lymph node areas on the same side of the diaphragm, it's stage 2. And at the time when you have a lymph node involvement on both sides of the diaphragm, then it's stage 3. And we talk about stage 4 when you have additional involvement, for example, of the bone marrow, or when you have diffuse infiltration of the lymphoma in organ, for example, in the liver, in the lung, or in the skin. Yeah, but in that stage, in that patient, we have cervical lymph nodes, we have mediastinal and retroperitoneal. So, and when we do that and we say, okay, it's lymphoma, we also check further because we know we have to treat that patient. We come to that in a second. And then we also need to say, okay, what is the organ function? How is the heart function? Then they usually get an echo. So we need to know how is the ejection fraction, the left ventricular ejection fraction. And we also do lung function tests because some of the chemotherapies that we give are toxic, especially they have associated pulmonary toxicity and also cardiac toxicity. And therefore you need a baseline before you give them the drugs. And in that patient, we've made the diagnosis of a classical Hodgkin lymphoma. Yeah, so we have a 19-year-old patient, stage 3 disease at least, with classical Hodgkin lymphoma. So what is a classical Hodgkin lymphoma? When I was a medical student, that was the first thing I somehow understood because that was kind of easier than understanding the non-Hodgkin lymphomas. A so-called classical Hodgkin lymphoma is a relatively common lymphoma, and it has 3 subtypes or 4 subtypes. It's called the nodular sclerosis subtype. This is what the pathologist sees when he looks into the microscope. So I'm not a pathologist. I'm very lucky that we have very good heme pathologists at our university hospital, very, very good. So it's because you need good pathologists to make in the end an integrated diagnosis, because sometimes it's not so easy to really find out what type of subtype of lymphoma you have. With classical Hodgkin lymphoma, it is not so difficult, although there can be cases where it's a bit tricky. And as I said, we have nodular sclerosis, the most common subtype. Then we have the so-called lymphocyte rich, the lymphocyte depleted, and the 4th type with mixed cellularity. But all of them are subsummarized under classical Hodgkin lymphoma. And what is very particular about Hodgkin lymphoma is that you can have, for example, a big mass of the lymphoma, but the actual malignant cells, and in the Hodgkin, they're called the Reed-Sternberg cells, they only make about 4 or 5% of the lymphoma mass. And the predominant population of cells building up that lymphoma mass are reactive cells. So CD4 positive lymphocytes, monocytes, or eosinophilic granulocytes. It's very, very particular and very different compared to other lymphomas. And what is also striking in lymphoma, in classical Hodgkin lymphoma, is that the Reed-Sternberg cells are CD30 positive. CD30 is a transmembrane glycoprotein expressed on about 90% of classical Hodgkin lymphoma cells on the Reed-Sternberg cells. And this is important because that can be a therapeutic target. And we come to that later. All right, and the question is always, when you have a young patient sitting in front of you, I mean, what they always do is, why is that? Where is it coming from? And that's a fair question, but we never do really know. And this is probably something general about lymphomas. There are some lymphomas that are associated with certain infections, for example, hepatitis, or when patients have underlying autoimmune disease, then they have a higher risk for developing lymphoma. Or, for example, patients who are really severely immunosuppressed, like patients after solid organ transplantation, when they have another kidney or a liver, then they have higher risk for developing lymphomas because of the immunosuppression. But if you have otherwise healthy individuals, in most lymphomas, we do not know what is the cause of the lymphoma. There are many theories about EBV infections, for example, because many diffuse large B-cell lymphomas or also Hodgkin lymphomas are EBV positive. But on the other side, we know that about 95% of the population are EBV positive, but do not develop lymphoma. Yeah? So it's not really clear. There are some cases where there are strong associations, for example, with the endemic Burkitt lymphoma in Africa, but otherwise in most lymphomas, we just do not know. And this is the shape of the incidence of the classical Hodgkin lymphoma. And this is what you always find in textbooks, and it's true. So you have kind of a double peak incidence of Hodgkin lymphoma. So you have, this is the age of the patients in years, and this is the incident cases per 100,000 patients per year. And you see overall, it goes to 8 over 100,000. And you see that overall, it's not a very common disease. It's not like frequent like breast cancer or colorectal cancer. It's relatively rare. But if you look in that disease, you have young patients between, let's say, 18, 20 until 30, 40. And then again, you have older patients. Yeah, it's a very typical two-peak pattern that you don't see in other lymphomas. So why Hodgkin? That's a bit of medical history. So Thomas Hodgkin was a pathologist in the 19th century, and he lived in London. And he was the first pathologist describing the blood disease Hodgkin lymphoma. And he was at St. Guy's and Thomas Medical School. And this is now subsidized to the King's College, where I also have this information. That's the King's College in London. I was there as a medical student, but just for 3 months. Very nice place to go. So what do we do with these patients? Overall, when we talk about classical Hodgkin lymphoma, even if you have an advanced stage, and if we talk about advanced stage, it means stage 2 or stage 3 or stage 4, then you have an advanced stage. So stage 2 depends a bit on the risk factors. I don't go into details, but overall, even if you have a stage 4 disease, the aim of treatment is to cure the patient. It's not a palliative treatment, so you don't have a palliative treatment intent where you say, okay, the disease is there, we treat it and try to kind of push back the disease, but we know it will come back. So that would be a palliative treatment intention. And on the opposite, we have the so-called curative intention, where we say we want to cure. So we do anything and the lymphoma won't come back because we know. And these are the progression-free survival curves and overall survival curves, just an example. So that was a study conducted by the German Hodgkin study group. They're based in Cologne, and they have a very long history of trials where they're really trial by trial optimized treatment for patients with Hodgkin lymphoma. And you see here, this is the progression-free survival, this is the overall survival over time. And you see the survival prognosis of these patients is brilliant. I mean, almost 100% do not die. And if you look at the progression-free survival, you can really induce long remissions. So you can really cure patients. Only a very small minority of these patients have a lymphoma relapse. Yeah. So, but how do you do that? How can you treat these patients? Also, as a medical student, I was always confused by chemotherapy protocols, and we also won't get into details, but because they also always change, and it also depends on what kind of study group and protocol you follow. They're different. So we just talked about the basic principles behind this treatment approach. When I was preparing that talk, I found this paper. It is published in the British Journal of Hematology, very recent, 2020. And it's very good because it is how I treat advanced Hodgkin lymphoma, a global view. And that's a bit what I found out when I prepared the talk, that most of the things I'm talking about and we base our evidence for is based on studies either done in Europe or America. And of course, some international studies are also done in Asia, but mostly based on the Caucasian population. And this paper is interesting. It's open access. So here they give different specialists from different countries, from the US, from Germany, from UK, from India, from Thailand. They give a case and then they describe how they would manage it. Very interesting to read. So, but basically what they all have in common is we have chemotherapy and we have radiotherapy. These are the two main backbones currently for treating classical Hodgkin lymphoma. And when we look at chemotherapy protocols, so this is just for completeness that I mentioned the different drugs. There are two big protocols, principles. One is called BACOP or BACOP, and the other one is called ABVD. These are two different chemotherapy protocols that have been tested by several research groups and several combinations, and so on and so on. And some believe in those, some believe in those. What they all have in common is toxicity. Yeah. So if you treat patients, so this is polychemotherapy. So you combine different chemotherapy drugs, and they all have a different mechanism of action, and they are toxic. But it's all manageable. Yeah? It's doable. These treatments currently in our setting, we can do that all in outpatient setting. So we do not need to admit patients to the hospital to give that treatment. We all do it in our outpatient clinic. It was different some years ago, but now we all do it in our outpatient clinic. And as you see, the BARCOP regimen has more chemotherapy drugs than ABVD, and is also more toxic. And when we talk about toxicity, so treatment side effects in oncology, hematology, we basically speak about the acute, so the short-term toxicities like anemia, leukopenia, infections, mucositis, diarrhea, vomiting, all these things. And then we have long-term toxicities like cardiac failure, probably chronic renal failure, fatigue, yeah, sometimes psychomotoric disorders, but that's very rare. Infertility, yeah, very important. And that also patients don't get back on their energy levels they had before. You know? And that's understandable because this is a lot of toxic stuff we give to our patients. But as I said, the aim is cure. But we know that many patients are overtreated. Probably some don't need so much treatment. And therefore, many studies have been initiated to reduce the burden of the chemotherapy. And this is why the so-called response-adapted treatment strategies have been developed. So that means if you say, for example, if you have advanced Hodgkin lymphoma, then in the past, somebody would say, okay, you need 6 cycles of this treatment, whatever it takes. Yeah, 6 cycles of the treatment. Treatment takes about 3 months overall, and then you're done. And then some people say, hey, come on, probably when you have a lymphoma that responds well after only 2 cycles of treatment, then you probably only need to give less afterwards. And these studies have been done with BARCOP and also with ABVD. So currently the standard of care would be to give chemotherapy and after 2 cycles do a PET-CT. And if that PET-CT shows a complete metabolic remission, that means the metabolic activity of the lymphoma, which is usually very strong, is absolutely or almost 0, then you can safely say, okay, we can reduce the intensity of chemotherapy. And by that, we spare toxicity, short-term toxicity, long-term toxicity, but also financial toxicity. So also the resources in the healthcare system used are less. And the classical Hodgkin lymphoma is a very good example how this has been developed over recent years. And for classical Hodgkin lymphoma, it's standard to do this so-called PET-adapted treatment approach. For other lymphomas, currently not yet. So coming back to our case, so the young man had stage 3B classical Hodgkin lymphoma. We gave him 2 cycles of escalated BARCOP. And the interim PET after 2 cycles shows a complete metabolic remission. As I said, okay, we don't need to give 6 in total. He just needs another 2. So overall, he has 4 cycles. And then also the final PET-CT after end of treatment shows an ongoing complete remission. So all fine. Yeah, I usually would say to the patient, very good, go home, you're cured. But there are some patients, up to 5%, they relapse. And that's why these patients, we have them in our follow-up for at least 5 years. We see them every 3 to 6 months, just do a clinical examination, do basic blood tests. But if the lymphoma is back, then we have to think what to do. And assuming now in that patient 2 years later, he has a relapse, there's the question what to do. Overall, if you have a young patient with classical Hodgkin lymphoma, also in that situation, if you have a first relapse, then you can still cure the patient. And usually what we do is we would give them high-dose chemotherapy, followed by autologous stem cell transplantation. So very basically speaking, you give them even more chemotherapy, but it's so much chemotherapy that usually the bone marrow would not come back. And therefore, before you give the chemotherapy, you have to collect the patient's own blood stem cells and then reinfuse them back after the chemotherapy. That's what we mean by high-dose chemotherapy followed by autologous stem cell transplantation. And if patients are not eligible for that because they're old, they have comorbidities, then you can, of course, not do it. But we have other drugs, the so-called checkpoint inhibitors. Probably heard about them. This is a very new type of immunotherapy where in the end you pull off the brake of the immune system to let your own T cells attack the tumor. And that has been is very successful, for example, in melanoma. But it is also very successful in classical Hodgkin lymphoma. It is not successful in other lymphomas so far, but in classical Hodgkin lymphoma or primary or mediastinal lymphomas, it is very successful, and that is associated with a certain genetic alteration that I mentioned here. And here are two publications that give really very good insight on these mechanisms. And the other thing is, one of the breakthroughs was the brentuximab. This is a new drug. It's a so-called drug antibody conjugate, where you have an antibody directed against CD30. And you may recall CD30 is expressed on almost 95% of Hodgkin lymphoma. So you can use that drug to treat Hodgkin lymphoma as a single agent. And then, of course, you have other chemotherapies that you can give, others than high-dose chemotherapy. So there's still some things you can do. Yeah, but still, classical Hodgkin lymphoma, you try to cure them with a first treatment. You don't want them to relapse. All right, so that was the first run through the Hodgkin lymphoma. And now coming back, so we talked about Hodgkin lymphoma, but this is just one type of lymphoma. And then we have the much, much bigger group of the so-called non-Hodgkin lymphomas. So as you see, this discrimination between these two groups is historical, yeah, because here it was Mr. Hodgkin who gave the name to the lymphomas, and then we have all the non-Hodgkin lymphomas that has been discovered by others. And these non-Hodgkin lymphomas comprise B-cell lymphomas, T-cell lymphomas. This is when you look at the cell or the type cell of origin, so from which lineage in the bone marrow comes the lymphoma. But you also have another possibility to look at the lymphoma. It's not whether it's B or T cell, but from the clinical behavior, yeah, where you say it's rather an aggressive, fast growing, making people real sick lymphoma, or whether it's a rather indolent lymphoma that slowly grows and is more like a chronic disease. And overall, if we look now at these non-Hodgkin lymphomas, most of them are B-cell lymphomas. Yeah, only a small fraction is T-cell lymphoma. In Asia, especially in Korea, Japan, and China, they have more T-cell lymphomas, especially the NK T-cell lymphomas coming from the nasal oral cavity. And then again, B-cell lymphomas can be distinguished by their clinical behavior, a rather aggressive lymphoma or indolent lymphoma. Of course, it's not a dichotomy. There's a gray zone between them. Yeah, it's continuous. It's not black and white. And the same accounts for T-cell lymphoma. However, most T-cell lymphomas are aggressive, and only a very small fraction are indolent. So the next cases will first really focus on B-cell lymphoma. And again, if you look at non-Hodgkin lymphoma and B-cell lymphoma, this is the list based on the current WHO classification. So we won't discuss all these subtypes. We will only discuss the most frequent ones. But yeah, this is the reference that gives you all these, an overview of all the lymphoma entities. So the second clinical case is you have a female patient. She's almost 50 years old. She's also otherwise healthy, swelling on the neck, the same thing. She has night sweats and feeling tired. And as before, we do a clinical examination, we do an imaging, and we try to get a diagnostic lymph node resection. And here we see that she has the enlarged cervical mass and she has really a lot of lymphoma involvement, including extranodal involvement. That means the lymphoma is not only in the lymph glands, but also in other soft tissue like liver, like pancreas, kidney, adrenal glands, skin, bone, bladder, central nervous system. So it can really involve anything. And the more it does, the worse the prognosis. And we have the diagnosis of diffuse large B-cell lymphoma. So what is diffuse large B-cell lymphoma? It is an aggressive lymphoma. It is the most common aggressive lymphoma, B-cell lymphoma. And it is characterized by large cells that do not respect the lymph node architecture. So they're really diffuse patterns of large blastic cells. And as I said, it's the most common type of the aggressive non-Hodgkin lymphoma. There are several ways to classify it. The easiest way is to say, okay, we have a diffuse large B-cell lymphoma not otherwise specified. It's the most common subtype. And there are two types, so-called the germinal center B type and the non-germinal center B type or non-GCB type. In the past, we thought that could have many clinical implications, but currently no. So all of them are almost treated the same way. Very important, diffuse large B-cell lymphoma carry the B-cell markers CD20 and CD97, and this is important. Coming back on the next slide to that. Just to confuse you a bit more, it is, of course, research is going on, and we try to decipher and understand further subtypes in order to better understand and treat patients. And this is a very recent summary, very nice summary, a review 2021 from the England Journal of Medicine, where they summarize the evidence how you can genetically define and classify diffuse large B-cell lymphoma. However, none of these things you see here, we don't go into details, has any consequence for treatment. Yeah, because the standard of care is R-CHOP. So it's rituximab and CHOP. CHOP is a chemotherapy regimen consisting of cyclophosphamide, vincristine, doxorubicin, and prednisone, and has been the mainstay of treatment over decades until rituximab, which was the very first monoclonal antibody used to treat humans. Yeah, it's a CD20 directed antibody, and that was the first trial they conducted in the 90s and then published 2002. R-CHOP, randomized versus CHOP, and this is survival. And the combination of rituximab and CHOP led to a significant prolongation versus CHOP alone, and therefore R-CHOP since then is the absolute standard of care for patients with diffuse large B-cell lymphoma. So this is probably a protocol you should keep in mind, R-CHOP, because this is very, very common. And there was also another bigger study seeing that again. You see always the red curve is our chemo or with other chemotherapies or CHOP-like, and this is chemotherapy without rituximab. Yeah. So it really is a big game changer and has really changed the way we treat diffuse large B-cell lymphoma. And that's what I found when I went a bit to the literature. It's also used in Indonesia. So this is a publication from 2020 when they did cost utility analysis within the Indonesian healthcare system. And before they did this analysis, I think they did a review at certain cancer centers in Indonesia and asked them, okay, how do you treat the diffuse large B-cell lymphoma? And most said we do R-CHOP. And when I understood correctly, this combination is also now covered by the National Health Insurance since 2014. So R-CHOP is also standard of care in Indonesia to treat diffuse large B-cell lymphoma. So are there any new standards coming? So is R-CHOP really still the big one? There have been many studies trying to beat R-CHOP, yeah, with other agents, combinations, and so on, and all of them have failed until recently. So there was one study, it's called the POLARIX study, where they combined polatuzumab, it's another antibody, also from the firm Roche. It is directed against CD79B. And as I said, showed you before, the diffuse large B-cell lymphomas are positive for CD20. This is rituximab, the antibody, and then 1719. And this is an antibody directed against 1719B. And it is not only an antibody, it's also an antibody drug conjugate. So it is an antibody bringing a chemotherapy drug directly to the cell, to the malignant cell. And when we drop the vincristine from the CHOP and replace it by polatuzumab, we see a benefit for the patients in terms of the progression-free survival. The progression-free survival is the time from you give the treatment until progression of the lymphoma or relapse or death. Yeah. But if you look at the overall survival, so whether you really make the survival prognosis for these patients better, there was no difference in survival. However, I think it is approved by the FDA and will also be approved by the European Medical Association very soon. So that may be the new standard of care. So another very interesting topic, I won't get into too much details, but I think it's important that you heard of it. It's the called CAR T cells, chimeric antigen receptor T cell therapies. This is a technology which is not entirely new. It has been shown in the 90s already, but since the last years, also big pharma companies have jumped on the train and developed this now as a product. In the end, the idea is that you collect for example, T cells, so cytotoxic T cells that are responsible for killing tumors and malignant cells. You isolate them from the patient's blood, and then you introduce a chimeric antigen receptor. So you genetically modify that cell, that this T cell expresses certain receptors, the chimeric antigen receptor. You expand that in the lab, and then you give it back to the patient, with the idea that this CAR T cell with this new receptor now directly finds the malignant cell and kills it. Yeah? And this type of treatment has revolutionized CD19 positive acute lymphoblastic leukemia, and is now also more and more used in lymphoma. And this technology and the products, they have differences regarding the activated domain and so on and so on. This is a nice paper where you can read about this technology. We won't go into details here, but this is something I think important that you hear about it. So CAR T cell therapy. And this is one of the examples recently published in New England Journal of Medicine, back to diffuse large B-cell lymphoma who relapse. So they receive R-CHOP-based treatment and then have the lymphoma is back. How do you treat them? Usually we would treat them with high-dose chemotherapy followed by autologous stem cell transplantation. Very intense, very toxic treatment. And here it was directly compared. You either give CAR T cells or you do standard of care. Yeah? And we see that the event-free survival and also the overall survival, although not significant, is prolonged. Yeah? So CAR T cells are a kind of new standard of care in relapsed diffuse large B-cell lymphoma. And another just important aspect, also just to give you that idea, is so-called circulating tumor DNA, ctDNA. That is, we are not only looking into PET scans or scans, but we also have more and more the possibility to search for lymphoma DNA in the circulating blood of the patients. This is currently not standard of care, but it will be, I assume, in some years, so that we more measure the circulating DNA in the patient and have therefore a much much higher granularity in assessing the disease and the burden of the disease for the patient. And this is one from one of my colleagues from Freiburg, Florian Scherer. He was in that lab in the US in his postdoc, and he's working on that. And this is very, very exciting. We have some hematological malignancies where this is already standard, for example, the chronic myeloid leukemia, CML. But for diffuse large B-cell lymphoma, also for follicular lymphoma, this is not the standard at all yet. So, but it will come to our clinics in some years, I assume. All right, so that was diffuse large B-cell lymphoma. Now we come to clinical case 3. We have a 55-year-old male patient. He's also otherwise healthy. And he has since 3 months slow swelling on the neck. And here's the same approach. If you're suspicious for lymphoma, of course, you do the clinic examination, you do imaging, and you try to get the lymph node excision. Core needle is possible, but always try to do the diagnostic lymph node resection. In this case, we only have a core needle biopsy. In a PET scan, we see here cervical involvement, and the core needle biopsy gives you follicular lymphoma. Because it was only a follicular, because you only had a core needle biopsy, the pathologist said, sorry, I cannot give you further graduation. Yeah, that is only possible if you have a complete lymph node resected. And we did a bone marrow puncture where no lymphoma is involved. And when we talk about follicular lymphoma, we're talking about the most common type of indolent lymphoma, so slowly growing, not immediately life-threatening lymphomas. And you can see here, again, I'm not a pathologist, but what I understand from pathology is that they have this kind of follicular growth pattern, yeah, and they still respect somehow the architecture of the lymph node. And they have very certain genetic alterations, for example, translocation 1418 or translocation of BCL. This is the translocation of BCL2 in about 90% of cases. So this is diagnostic. This is something the pathologist must know to diagnose follicular lymphoma. And they are graded into grade 1, 2, 3A and 3B. And this is based on the number of central blasts and large cells. However, if you have follicular grade 3 and grade 3B, this is very similar to diffuse large B-cell lymphoma. Again, CD20 positive because it is a B-cell lymphoma, so CD20 is a B-cell marker. But in contrary to diffuse large B-cell lymphoma, they are also CD10 positive. This is, as I said, it's important for the pathologist to make the diagnosis. And in that case, the patient only had swelling on the neck, so it's only one field where the lymphoma is sitting. And in these cases, although it's an indolent lymphoma, and although usually indolent lymphomas, we say we cannot cure them, yeah, because they will always be there, waxing and waning over time, over years and decades. In these cases, when you have really disease only at one lymph node field, you can give radiotherapy, not chemotherapy, with curative intent. So give a lot of radiation here, and then you hope you have cured the patient and the lymphoma will never come back. That does not work out in most patients, but it's worth to try. But even if, for example, consider the same patient, he has swelling here, and swelling in the abdominal cavity, but he has no symptoms at all, then it's not necessary to start treatment. So what we do in these patients, we say, we watch and wait. We do nothing. Yeah, we do nothing. And there are some criteria. So one is, of course, clinical symptoms, B symptoms, pain, changes in the blood count, and so on and so on. And of course, for some patients, it's strange. You say, I have a lymphoma, I have a kind of malignant disease, but doctor, why don't you do anything? And then I say, I could, but it won't change anything. Yeah, and probably you have side effects from the treatment. You probably get infections, and I don't want that. Yeah, so in these cases, we watch and wait if there is no clinical indication to start the treatment. And if the patient has symptoms, yeah, night sweats, anemia, then we treat. And the mainstay of treatment here is still immunochemotherapy. So it would be rituximab or a newer antibody combined with chemotherapy. But there are also approaches without chemotherapy. So where you give only type of immune therapy. A Roche R square is, for example, the combination of rituximab and lenalidomide. All right, then we come to our last case. We have a 70-year-old male patient, a swelling on the neck, night sweats, anemia, and rash. We do the same workup, clinical examination imaging. I forgot the viral serology, and also try to get a biopsy. And here you see also a patient with stage 4. So overall, skin is involved. A lot of lymph glands are involved. And we found peripheral T-cell lymphoma. And also in the bone marrow, we found T-cell lymphoma. So as I said, T-cell lymphoma is a rare disease. It's very aggressive, and most patients die of it. So in these cases, we only cure about 20 to 30% of patients, if at all. Yeah. As I said, is aggressive. Also with the T-cell lymphomas, you have many different types. Again, here is the classification of the disease, WHO 2008. But most of these peripheral T-cell lymphomas are CD30 positive. You probably remember CD30 positive is also the Hodgkin lymphoma. And this is a trial where they combined CHOP. You have heard it. So CHOP also here is the standard treatment, or was the standard treatment, but combined with brentuximab, the CD30 directed antibody drug conjugate. You see the blue curve where you can certainly see a benefit for the patient. So for this rare disease, we have effective treatment, but you still see that almost 50% will eventually relapse from the disease. In that case, we had stage 4B. We gave him ACHP, so that's brentuximab, cyclophosphamide, doxorubicin, prednisone, and the early interim PET already showed a complete remission. And then I see this is wrong. This should be 4 instead of 2, given some other rounds of chemotherapy, and the patient is still in ongoing remission. But this you do not achieve in the majority of patients, unfortunately. Most patients don't achieve a complete remission with peripheral T-cell lymphoma. So, and here we are already at the summary. So I hope I gave you a more or less good overview about lymphomas. The first take-home message is lymphomas are very heterogeneous, very type of different kinds of disease. That's why I like treating lymphoma, because you have young patients, you have middle-aged patients, you have old patients, you have aggressive disease with intensive treatments. You have patients that you can watch and wait just with mild treatments. So it's a very, also from the clinical management perspective, very heterogeneous picture. The most common type are B-cell lymphomas, and a lot of investigations and developments are going on in that case. Still, most patients you treat with immunochemotherapy. That's still the mainstay of treatment. And aggressive lymphomas we can cure, or some will relapse, but there's always a chance for cure. And as I said, some indolent lymphomas, they can be managed just by watch and wait. So no active treatment. And as I said, it's very, it's exciting. So a lot of new biomarkers and a lot of immunotherapies coming up, and likely that will change the treatment landscape. And probably during my career as a doctor, I hope I will see the time when we don't have to give chemotherapy anymore, but treat these patients probably only with immunotherapy approaches. Thank you very much.
Okay. Thank you very much, Dr. Kasenda. It's very insightful lecture. Yeah. Well, you said before that for medical student, it is confusing about lymphoma. Actually, not only for medical students. Me, myself, as anatomical pathologist, lymphoma is still very challenging, very challenging, especially in practicing, because, well, here we still have limited resources. PET scan not available everywhere. So yeah, it's pretty challenging for us. Well, so now we will proceed to question and answer session. Is there any question maybe? Okay. Here from Dr. Ivan. Okay, Dr. Ivan, I think to be more interactive, how about you ask yourself directly to Dr. Kasenda? I think it's okay, right? IT team, do you mind, Dr. Kasenda, if Dr. Ivan asks you directly?
Of course, directly. I think it's easier. Yeah.
Yes, of course. Please, Dr. Ivan. Hello. Tidak aktif. Oh, maybe you just can unmute your speaker and talk directly. It's okay. Don't be shy. Okay, I think I'll read his question.
Okay.
Wait a minute. Okay. He's asking about chemotherapy. What is the chemotherapy drugs choice for B-cell lymphoma and non-B-cell lymphoma, especially for marginal zone lymphoma?
For marginal zone lymphoma.
Yes, marginal zone lymphoma.
Oh.
Yes, that's the first question.
Okay, so marginal zone lymphoma is also heterogeneous. So you have splenic marginal zone lymphoma, you have the so-called nodal marginal zone lymphomas, and you have extranodal marginal zone lymphomas. And extranodal marginal lymphomas may also include this MALT. So if you have lymphoma in the stomach, for example. So if, for example, you have marginal zone lymphoma only in the stomach, then we try eradication therapy as you would treat HP positive gastritis with positron inhibitors, proton pump inhibitors and antibiotics. And if that doesn't work, we give radiotherapy. But if you have the indication to give systemic treatment, then the choice would be, you have the choice, for example, with rituximab and chlorambucil. Chlorambucil is a very old chemotherapy drug. We can take it with tablets. And the other way would be rituximab and bendamustine. Yeah, so these are the two choices for first-line treatment. Usually these marginal zone lymphomas are indolent lymphomas. You could also watch and wait if you don't need treatment, but we don't give R-CHOP anymore. Some do, but we don't do R-CHOP. That's too much. So our chlorambucil, rituximab chlorambucil, or rituximab bendamustine.
Okay, so no R-CHOP for
No.
marginal zone lymphoma. Okay,
Too
that's
much.
the first question. Too much. Okay.
Too much.
I'll ask the second one. How do you think? He's asking about the worst prognosis for lymphoma, or which subtype is the worst one?
You mean B-cell lymphoma?
Yes, B-cell lymphoma.
B-cell lymphoma. It really depends. So one of the things with diffuse large, so if you very talk in general, then when I was at Mr. Cunningham in London, he says, so 2/3 you cure and 1/3 probably will relapse and die. Probably it's a bit better now, yeah, but this is kind of the rough estimate. So when you talk about prognosis, I mean, there is the so-called IPI, the International Prognostic Index, which includes age, the LDH, lactate dehydrogenases elevation, yes or no, extranodal involvement, age, clinical performance status, and stage. So by that, you can kind of build risk groups. And of course, you more have adverse factors, the worse the prognosis. And if you, let's say you have all these factors, then survival prognosis is probably only 30–40%. Yeah, when you look at 5 years. I don't know how it is nowadays if you have the possibility to give the patient CAR T cells, and that probably that makes prognosis better. But overall, if you have a full-blown diffuse large B-cell lymphoma, especially a lot of extranodal involvement, and there are some particular involvements, for example, if you have involvement of the kidneys or the adrenal glands, or the breast, and also the CNS, then you have high risk for relapse and death. So these patients, when we have young patients, try to give them more intensive chemotherapy than only R-CHOP. But this is difficult because there is no randomized trial saying you have to do this and this. So if you go to MD Anderson, you will always receive dose-adjusted R-EPOCH. If you go to Bern, to the capital of Switzerland, they probably do high-dose chemotherapy straight away. We do a bit in the middle. So it's difficult.
So there are many clinical settings that must be considered.
Yeah.
In this case, talking about the prognostic factor, right?
Yeah.
Okay. Dr. Kasenda, this question is from me. I mean, as you said before, lymphoma is very confusing for medical students, and because now we are having a very broad spectrum of participants, since the first grade medical students until the lecturer. What is your message for the medical students? What is the lowest requirement or the yeah, the lowest requirement that they must know about lymphoma as a medical students? What do you think?
That's a very good question. So the first thing is, I think, is that if you examine a patient and you have a patient who has symptoms and you feel enlarged lymph glands either in the neck or axilla or in the groins, then one of your differential diagnoses should be lymphoma. Always. Yeah. Second, if you think, okay, that it could be lymphoma, then you should do a diagnostic lymph node resection. Yeah, if possible. Not only biopsy, but take a lymph gland out. And then the pathologist is happy because you have a lot of material and can better make the diagnosis. I think this is one thing. The other thing is that you know what B symptoms are. So B symptoms are night sweats and fever of unknown origin and weight loss, unintended weight loss. So the B symptoms, this is, I think, very important. So this is from the clinical side. And then you should know, okay, there are Hodgkin lymphoma and non-Hodgkin lymphoma, and that there is B-cell lymphoma and T-cell lymphoma, and that they are heterogeneous and that there are even lymphoma that you can watch and wait. I think this is very important because you have that seldomly when you talk about malignant diseases that you don't do something, but in lymphoma you can. Also in some solid tumors, but we don't do it very often. But in really in indolent lymphoma, do not harm. Yeah, don't treat if not necessary.
Yeah. Okay. So this is especially for medical students. Okay, all the students that join us today, you must remember Dr. Kasenda's message. Yeah. I hope it will help because lymphoma is very challenging. Yeah. And okay. And any other question maybe? If I'm not mistaken, Dr. Wilson, you have a question, right? Dr. Wilson.
Okay.
Okay.
Thank you. Thank you, Dr. Iran. Thank you, Dr. Benjamin Kasenda, for your lecture. It's very interesting. I want to ask a question about what is the current gold standard therapy in Hodgkin lymphoma, especially in Switzerland, from the chemo, radiotherapy, or CAR T cell when it is used in lymphoma, or is an gold standard, or just an adjuvant therapy like that? Thank you.
You mean for classical Hodgkin lymphoma? Okay, so for classical Hodgkin lymphoma, if you are young and fit, we follow the treatment approaches of the German Hodgkin group, because the German Hodgkin group, they proclaim the BRCOP regimen. If you are in the US, they will hardly use it. They will only give ABVD, depending on the stage, 3 times, 4 times, or 6 times. But in here in Switzerland, we follow, for example, if you have advanced Hodgkin, stage 4, we start with BRCOP, 2 cycles, we do a PET scan, and if the PET scan shows a complete metabolic remission, it's only another 2 cycles, and that's it. If the PET scan is positive, we go on with 4 cycles and do another PET scan at the end. And if this is negative, that's it. If it's positive, then we give radiotherapy to the part where it's positive. So this is for advanced stage. If you have very limited stage, early stage Hodgkin lymphoma, then we give 2 cycles of ABVD and a bit of radiotherapy, 20 gray. That's it. So these are the 2, and then there's something in between. But these are, if you're advanced and early, these are the treatment approaches.
Okay,
So,
thank you, Dr. Benjamin.
Okay. Is it correct? Is it clear enough for you?
Yeah. Yes.
Okay. Okay.
Maybe from me.
Yes,
Dr.
Prof,
Irin.
please.
Yes. Dr. Kasenda, I am actually as a thoracic surgeon. Can you give me how far the treatment of isolated lymphoma in the thoracic cavity after you diagnose? Maybe you send to the surgeon or you treat the non-surgical treatment.
Very good question. So It depends what type of lymphoma. So
Yes.
what you can have. So what is in the thoracic cavity is, so if you have mediastinal lymphoma, so for example, Hodgkin can always be is often in the mediastinal mass. And the other lymphoma often in the mediastinum is the primary mediastinal lymphoma. So these lymphomas must be treated with chemotherapy. But there are lymphomas, the so-called broncho-associated lymphoma tissue, that are really in the lung parenchymal. And sometimes there are only solid spots. And it's a rare disease. But these, if you can then we ask the thoracic surgeon, can you resect it? And says, of course I can. I mean, surgeons can always resect. Then they do resection, and then we do nothing. We just watch and wait. So this is an indication where surgery plays a role. Sometimes what we also have is, and that's always the question, if you have a suspicious lesion, the surgeon goes in, takes that out, and we say, oh, it's lymphoma. And then it's out, and probably we do a PET scan and nothing else is there. And then we ask ourselves, okay, is that now enough? Do we need another treatment or not? Even for diffuse large B-cell lymphoma, we sometimes ask, is it now really necessary to give 6 cycles of R-CHOP? This is unclear. There's always then a long debate in our discussions.
Okay.
Yeah.
Okay. Once more, in Indonesian, that's Dr. Irens has explained that sometimes we are confusing about the mass in the neck. Yes, especially in Indonesia, there are so many tuberculosis disease, and how we compare, how we diagnose, differentiate with the lymphoma when it is a mass in the young or in the children in the neck. So many multiple tumor like lymphoma, and how we can differentiate it with the tuberculosis.
This is certainly different compared to Western countries, where we have not so many infectious diseases as differential diagnosis. But in Indonesia or India or Africa, you have many more other infectious causes of a mass, and you don't want always puncture children or whatever and get resections of that mass. I think what is important is the medical history. That we come back to the basics of medicine. It's medical history. Is it a young guy from Jakarta living in a higher standard of living, or whether he's from a rural area? And then it's of course the dynamic of the disease or the dynamic of symptoms. I think it's important to appraise. And and I think then it must be a good mixture of the clinical appraisal. And then to make the indication, okay, we need a biopsy now, or we can wait. Okay. And what I think is also important is that the pathologist knows about the medical history. We also have that problem here. So the pathologist gets something, and there's only one sentence in his, what is that? So I think it's important that the communication between the clinician making the indication, I want this, and then he also tells the pathologist, I have that in the background, because then he looks differently at the specimen. Yes, it's important.
And the point is, we must know about the medical history. Yes. Yeah. The point here, because sometimes we confuse about this mass in the neck, and might be this the last question. Is there a place to treat the lymphoma, isolated lymphoma? For example, in the leg, lower extremity, isolated lymphoma with that we call that extracorporeal circulating. It is a place to treat with the extracorporeal circulating.
Extracorporeal circulating.
Yeah, like we give.
I understood. I know.
Yeah.
So you give only cytostatics to the leg, and you close the artery and the vein. Yeah, in the groin.
Okay. Yes.
No. So I know we did it. So there were indications for sarcoma and also for melanoma in the past.
Yes.
We don't do it anymore. And then especially for lymphoma, if you have lymphoma of the lower extremity,
Yes.
then and if it's on the skin, then it's very likely to be the so-called diffuse large B-cell lymphoma leg type. And these leg type lymphomas are very aggressive. They will relapse, and they usually at some point they spread into the body. So these patients we will certainly treat with chemotherapy. Interestingly, I had just 2 patients. Most of them are elderly with leg type lymphoma, and sometimes difficult to treat because they have comorbidities and so on. But usually this is a very aggressive lymphoma. And both of my patients, they died. They had only in the leg. We treated them. They relapsed 12 months later. So you need to treat it. Yeah.
Yes. Thank you very much for your explanation. And you know that's most of the participant, our student, medical student, might be you can tell how SAU can study in abroad from the medical school or from the high school. I don't know. Can you tell? Can you explain to our student how get this scholarship might be to study in Switzerland or in Germany? Like I read your CV, so very, very, very good. What you reach, what your career is. Can you explain to our student?
Yes, thank you very much. I think, first of all, I think it's very important. So I was very lucky because I always had very good teachers. I had very good teachers, I had very good mentors. They supported me, they trusted me. They say, Benjamin, do it. Yeah. And I think this is important. So the team, yeah, you need good people around you. And the second thing is that the easiest way, of course, to get abroad is if you have kind of money, because then it's easier when, for example, you want to do a clinical scholarship in London, or you want to go to Singapore, or you want to go to Brisbane or whatever. Of course, you need some support. And it's same for us here. So I was only able to go into London because there was a grant here in Switzerland. I applied for that grant and I said, okay, it's nice what Benjamin is doing. So we give him some money and he can go to London. And this is, I think, always the same, isn't it? You have to apply for a grant and then they give you some money and then you can go abroad. And I think important here is this does not come by itself. So if you want to do it, wherever you are in this world, you need to work hard. And when I was a younger doctor, of course, you have to do a lot of work in the clinics and you have to learn. But if you want to have this grants, okay, then it's extra. Yeah, then you have, of course, to sit down and write the things. And I think it is, how to say it? So, and if you apply for a grant, at least here, if you can only show, hey, I already did this work, this scientific work, I have this little paper, and then they see in your track that you are really encouraged and to do it, then the chances are higher. Okay. And in general, I would always say, if you have the possibility to go abroad, do it, because that really opens your mind. When I was in London, I mean, this is a different healthcare system than Germany or Switzerland. It was great. And there are so many things I learned here where I say, hey, we can do better here in Switzerland. Although Switzerland is richer than UK, but still they did some things better than they do here in Switzerland, certainly. Some things are worse, some things are better. And that really opens your medical background and also the way you think about how medicine works, because medicine is always an integral part of the conditions and of the culture you work in, always. Of course, there's also the science that should be same for everybody, but still, yeah, there are differences.
Okay, thank you very much for your explanation. And I hope our medical student can get something from you. And maybe next time we can ask for you to give a lecture again when you have time and
of course
willingness. And please give your experience to our medical student to open up inside how far the advances in medicine in abroad. Thank you very much. I think I have lucky too. I have a scholarship from the Germany government, and I study in cardiothoracic in Erlangen-Nuremberg University. Yeah.
Okay.
South Deutschland, and 3.5 years. Okay, thank you very
Interesting.
much.
Okay. Was
So,
a pleasure. It was very nice.
Yeah, nice, very nice talking to you.
Thank you, Professor Paul. I have one more question actually, Dr. Kasenda, from Dr. Nilu. She is one of our lecturers. Is there any way in clinical setting we can differentiate T-cell lymphoma or B-cell lymphoma?
You mean from the clinical behavior?
Yes, clinical behavior only. Is there anything distinct about them?
Difficult. Let's put it the other way. T-cell lymphomas are more difficult to diagnose.
Yes.
Because sometimes they, and also from a clinical perspective, because they can sometimes present with very, very funny symptoms, itchiness, a bit rash, a bit of fever. There's no real mass. So I remember one patient, she was 70 something, but otherwise fit. And then she came to the general medical ward. It was when I stayed in Freiburg, so some time ago. And she had fever, a bit of fever coming and going, and was not fit. Yeah, and she came, and then we did a scan. We did not find really enlarged masses, probably one lymph node, 1 centimeter, something like that. We did a bone marrow biopsy. It was just kind of a bit reactive, but nothing really inside. But she always had these fever spikes. We did a lot of tests, bacteria, fungi, nothing. And then I think after 3 weeks or something, we found, we did another flow cytometry analysis, and then we found a T-cell population. And based on that, we made the diagnosis of peripheral T-cell lymphoma. And then the disease really whoosh, went off. And then she developed lymph glands and so on. She was dead within four weeks. So the take-home message for me was that that T-cell, and you don't have that with B-cell lymphoma, usually not. B-cell lymphomas mostly are quite straightforward in a way to diagnose them. But because T-cell lymphomas are rare, you have so many subtypes of T-cell lymphoma, the clinical presentation can be very, very fuzzy sometimes. That's why some people call it T-cell lymphomas like chameleon. So it is something like that, something like that. That's the only difference, I would say. I mean, probably T-cell lymphoma have a bit more skin involvement, itchiness, rash, something like that. But to be sure, in the end, you need to get a biopsy anyway, and have a good pathologist.
It's difficult to diagnose T-cell lymphoma because sometimes it looks like inflammatory cells, nothing specific, and and there is some limitation in immunohistochemistry here in Indonesia. Not all center has a complete panel of lymphoma, so it's pretty difficult, I guess.
But can you do a clonal analysis of the T-cell receptor?
Yes, in some center. I think only in Jakarta right now. Here in Surabaya, we still don't have that facility. It's pretty difficult lymphoma here in Indonesia.
Yes, I can imagine.
So, well, maybe another question. I really hope there will be a question from medical student. Okay, Jennifer, good. Please, Jennifer, do unmute your speaker and also your video and talk directly to Dr. Kasenda, please.
Okay, thank you. Thank you for this opportunity. Good evening, Dr. Benjamin Kasenda. So I'm Jennifer Meredith, currently a second-year medical student here in Widya Mandala. Thank you for the wonderful material given. I have two questions actually. The first one is related to Dr. Wilson's question earlier. So how can we choose between giving our patient chemotherapy, radiotherapy, or immunotherapy? What are the considerations that we should have in order to choose between those three, and the reasoning as well? And I'm very curious about the CAR-T cell treatment. I'm wondering if there's actually a potentially lethal side effect of that treatment, and if there is there a way that we can alleviate that? Thank you, Doctor.
Okay, so I hope I understand it correctly. So the first question is about how to decide when to give chemotherapy, immunotherapy, or radiotherapy, and so the broad principles. And the second question was about CAR T cell treatment side effects. Sorry, I didn't understand it acoustically. What was the question?
Yeah, Doctor, the CAR-T cell treatment side effect. Is there a potentially deadly or lethal side effect or severe side effect? And if there is,
okay. All right. Yeah, no, of course. Okay, the first thing is, so, okay. So basically, so in all types of lymphoma, so in all B-cell lymphomas, rituximab is part of any treatment, whether you do it alone with CHOP or bendamustine or another chemotherapy. So in general, you can say for B-cell lymphoma, because you're CD20 positive lymphoma, they're always treated with a CD20 directed antibody. And the most common used one is rituximab. I think this is probably one of the main principles. And then regarding chemotherapy, this is what type of chemotherapy you choose. In some lymphomas, it is clear. Yeah, so this is the standard. For example, CHOP, that is the CHOP backbone chemotherapy for treating diffuse large B-cell lymphoma. But of course, there are clinical situations. For example, when you have an older patient who has chronic heart failure, so ejection fraction of 30%, he already had 2 heart attacks and so on and so on, you don't want to give him doxorubicin. Doxorubicin is an anthracycline. It's a strong chemotherapy agent, very effective, but it comes with very high a risk for cardiac toxicity. And in these patients, you will be very hesitant to give that because you may kill the patient if you give that drug. Yeah. So in these situations, you have to choose something else. For example, gemcitabine. And this is something we really have to consider. So it's with the cardiac comorbidity. And the other thing is also the pulmonary comorbidity. For example, we talked about the BEAR-COP protocol. There's bleomycin. It's an old drug. It's very cheap. But bleomycin can induce lung fibrosis. And the risk for lung fibrosis is increased if you have a history of smoking. I know in Indonesia, many people smoke, especially many men. And this is an increased risk. And I've seen 2 patients, young patients, they had an acute fibrosis and they ended up in ICU and died. This is very, very rare, but that can happen. But if you have a history of smoking and want to give bleomycin, you need to be aware of that. And I always tell and for example, Hodgkin patients are mostly young patients. And if they come to my clinic, ask them, do you smoke? And then they say, yeah, sometimes I said, stop it, don't. I mean, what they do afterwards, I mean, this is their business, but during the chemotherapy, no smoking, because of the bleomycin. It's very important. So there are things, certain, and these are just 2 examples. So it's cardiac toxicity, it's pulmonary toxicity. And there are also other chemotherapies that can affect the kidney function. Yeah? So you can't give them, or you have to reduce them according to the kidney function. And there are some, so this is about how to choose chemotherapy, just the basic principles. And when it comes to radiotherapy, this is a very important point. For example, if you have an early stage Hodgkin lymphoma, for example, you have a young woman, 22, Hodgkin lymphoma, but here in the mediastinal. So the standard would be to give 2 cycles of ABVD and then radiotherapy. But we know radiotherapy, maybe we cure the Hodgkin lymphoma 98%, but the radiotherapy causes breast cancer 20 years later. Yeah, because this is a region which is very sensitive. So in these situations, we sometimes say, okay, we probably just give 3 cycles of chemotherapy, but drop the radiotherapy. Yeah. And this is especially in Hodgkin lymphoma, we sometimes have these discussions. So what is the risk later? Because we know we can cure, but what happens 10, 15 years later? especially in young patients. If you have a 70-year-old patient, it's different because it takes years until they develop cancer that is associated with radiotherapy. But in young patients, you have to think about it. Yeah, and that's why also all young patients with lymphoma, we ask them, do you have children, or do you still want to have children? Yeah, because with the chemotherapy and radiotherapy, they're genotoxic. So probably they don't have any fertility then later on. So they can then we send them to the endocrinologist, probably for sperm banking, or sometimes for women, they do also ovarian collection, if there is still enough time before we start treatment. Does that answer your question, the first question? Yeah. Okay. And then the second question was regarding side effects of CAR T cells. So that's important. CAR T cells, yeah, it's a nice construct and a nice technology, but it comes with side effects. So there's never a free lunch. And interesting with CAR T cells, typical side effects are the so-called cytokine release syndrome, CRS. And that is likely it's like an inflammatory reaction. Looks like sepsis, but it's not a sepsis caused by bacteria, but it's just this inflammatory reaction to the CAR T cells, because these CAR T cells trigger the immune system, and that can really lead to overreaction. And in some patients, it is not only the overreaction, but it's only in a specific so-called neurological side effects. So some of these patients can go to ICU because they're completely out of nowhere, but that recovers after some days, and then they're back again. So that can be very, very strange. So cytokine release syndrome and so-called ICANS is the immunotherapy caused adverse neurological syndrome or something like that. So there's a very specific side effect for these CAR T cells. That's why you need dedicated centers where the patients are treated, where we know how to deal with side effects. Does that answer the question?
Okay, yes, doctor. May I ask another question?
Yeah.
Is there a way that we can minimize or alleviate the side effect of CAR T cells?
How you can minimize the side effects? So one approach is, it depends a bit on the product. So the chimeric T cell antigen receptor, they have generation 1, generation 2, generation 3. So they have different ways how they stimulate the cells. So there's some technical difference how you create the receptor, and that can reduce side effects. So some people say third generation have less side effects. And the other thing is that you give that you intervene earlier. For example, with tocilizumab, this is a TNF antagonist, so that you try, if the side effects, that you monitor side effects, and once they come, that you treat, and don't wait too long until you treat the side effects. These are just basic principles how you can minimize the risk. But overall, the side effects are manageable. So most patients have no side effects at all. They're just on a ward. They say, do they get treatment? Yeah, they do, but nothing happens. So overall, it's really an advantage in how we treat them.
Okay, thank you, doctor.
You're welcome.
Okay, thank you very much, Jennifer. Well, I guess there are still many questions, but yeah, it's too bad our time is limited. So maybe next time, if you have some other time, you can do this again, Dr. Kasenda.
I have another 5 to 10 minutes. It's okay.
Oh, it's okay.
It's a babysitter
Okay,
with the
then.
children, so I don't have to. It's all right.
Okay. Well, so there is a question about management of indolent lymphoma. It's interesting because you said before that it is better to wait and see. And to be honest, it's very difficult to tell a patient to wait and see, especially when we tell them that they're having a malignant neoplasm or lymphoma. So can you please explain more about this type of wait and see? What do we see, or what do we wait for? Anything?
Yeah, it's a very interesting question, because it is not easy. I mean, as you said, you talk to a patient and as you give them diagnosis, you have a malignant disease, and but we don't do anything now. So that's difficult. So communication to the patient in that situation is very important. What I always tell my patients is that the best biomarker we have is time. Yeah, because, for example, you see the patient for the first time and he says, I have that swelling since 3 months. Yeah, and I'm otherwise feeling good. And then we did a biopsy and say, okay, it's follicular lymphoma, stage 3, whatever. And otherwise fine and active and does sports, whatever, is working. And some patients, it depends also on the type of patient. So some patients, they understand and say, okay, I can accept it's a chronic disease. Sometimes I say, you know, it's like chronic heart disease or chronic pulmonary disease, or it's like diabetes. You cannot cure it. Yeah, you have to somehow manage it over the time. And some patients, they can get along with that easily, especially when they're a bit older and they have a bit of experience in life and know what it means, and probably they have other medical problems that are more prominent than follicular lymphoma, for example. But there, of course, sometimes if you have young patients, I mean, especially when young patients, they want to do something. I had one patient, she was 25, and that's pretty young for developing indolent lymphoma. So there must be something that we do not know in the genes, but she had it. And for her, it was impossible. It was impossible to do nothing. And then we said, okay, then we do something. And we just give, for example, rituximab monotherapy. And we know that it works. And there's also been a study, to complete that topic, there was a study in the UK where they had patients with follicular lymphoma, with indolent disease, where otherwise, from a clinical point of view, you don't have an indication to treat. And they randomized the patient into single treatment with rituximab and watch and wait. And those patients that received rituximab, of course, they had a better progression-free survival. Of course, you can control the disease with rituximab. And also the time the patients needed treatment was longer, yeah, with rituximab. They just gave, I think, 4 cycles and that's it. But the overall survival was absolutely the same. Yeah, and they also looked into the quality of life, and interestingly, those who got the treatment had a better quality of life. Yeah, I mean, this is an argument where you can say, of course, if the patients want, you can treat them, and if the insurance pays. Yeah, because here in Switzerland, if you only give rituximab alone without chemotherapy, you really need to talk to the health insurer. It's not like, I think Indonesia has now a tax-funded health system, huh? Or do you have different insurance companies?
We have
Because here
different insurance companies.
You have also insurance companies. Because here, then you have to talk to the insurance companies, say, hey, this is the situation, if we want to do this and that. And then they say, no, we don't pay it. Then, okay. But most of the patients, to be honest, I talk to, they accept saying, okay, I do nothing. But I say, okay, I see you every 3 months. You come here. If you have clinical symptoms, you can come earlier. We do blood tests every 3 months. We can do ultrasound to check whether they're getting bigger or not. And then they feel kind of secure. So you need to give them something. You need to kind of give them a structured follow-up. And I think then it's feasible. But there are always some patients who do not feel safe with it and they want to get treatment, and then they go to another hospital and ask another doctor, and probably they say the same, and then they come back to you, and yeah. But that's natural. That's okay.
That's life. Well, I think I can understand, especially when they having a very many neck swelling or groin swelling, and we only say, yeah, we just wait and see. I think, yeah, sometimes it's almost
true.
impossible. Yes.
Yeah. And then sometimes what we do in that situation, so if it's probably very good point, if they're kind of from a cosmetical appearance point of view, yeah, then we say, okay, we just give radiotherapy to that lymph node and we'll go down, and then we're going to go on watch and waiting. That's also another possibility.
Okay. Yeah. Well, next question from me again. Since I'm a pathologist, why is it very different approach for grade 3A with grade 3B in follicular lymphoma? I mean, in grade 3B, you approach it as what aggressive lymphoma, right? 3A, indolent lymphoma.
Yeah.
Why?
So
why is that?
It's a good question because we always did it like that. No, no, I think so. If you ask, so our lymphoma pathologists here, they are really good, and they say if they look at 3B, then we put it another way. Usually, those patients who have a follicular 3B are more likely to have symptoms, are more likely to have advanced disease, and sometimes the pathologist cannot tell whether this is a follicular lymphoma or whether this is already on the way to transformation to a diffuse large B-cell lymphoma, because this is an event which is serious. Yeah? So when indolent lymphoma becomes aggressive lymphoma, just by the natural development of the lymphoma, then you certainly need to do something. And sometimes in 3B, you can't tell, is it a follicular lymphoma 3B by itself, de novo, or is it on the way to transformation? That's sometimes difficult. And then also, as I said, the clinical behavior is different when we look at the earlier studies. I mean, it would be interesting, but this trial does not exist, that you say, okay, if you diagnose 3B, you randomize treating like follicular lymphoma or treating like aggressive lymphoma, but that trial has never been done so far. And 3B follicular lymphoma is also not so common, to be honest. So it would be difficult to do such a trial.
Okay, well, okay then. Thank you very much. Still, is there any other question for this last few minutes? Okay, so we're still having our medical student here, Laurentius Raka. Please, Raka, unmute your speaker and talk to Dr. Kasenda directly.
Yes, thank you for the opportunity, Doctor.
Yeah.
Raka?
Yes.
Okay.
Is my sound loud and clear, Doctor?
Yeah, very
can
clear.
hear you.
Oh, yeah, okay. I have several questions for Dr. Kasenda. By the way, good evening, Doctor. On classical Hodgkin lymphomas, how do we manage the toxicity from the medication if it already happened? Are there any antidote to the current chemotherapy as in the Boku protocols? And the second one is, how do we make sure there are not any risk factors for the patients to develop a toxicity towards the medication holistically if we didn't admit the patient to the hospital? Thank you.
Yeah, good questions. So now we're almost on a special level for the exam in medical oncology. No, so management of side effects. So that's very important because if things go well, everybody can do their treatment, isn't it? I mean, giving drugs, it's different to being a surgeon. As a surgeon, you need to train and you really need to know how to use your hands and fingers. With treatment, you give it. But the things come when things don't go so well. Yeah, then you really need people who know what they're doing. And with treatment of Hodgkin lymphoma, so first of all, you have young patients, and usually young patients, they're fit, yeah? So they can tolerate a lot. I mean, humans can tolerate a lot anyway, so they can tolerate a lot of treatment. And we know hematological toxicity, so cytopenias, they come all, we know that. We know. So if they have thrombocytes of 20,000, 10,000, well, so what? When the patient is not bleeding, we don't do anything. Yeah. What we do is, of course, for example, if we look at the heme toxicity, if you have anemia around below a threshold of 70, hemoglobin of 70, and patient is symptomatic, then we transfuse the patients. If you have platelet counts below 10,000 and or patient is bleeding with 20,000 thrombocytes, then we give the treatment. We give transfusions. Yeah. So hemoglobin, platelets, there are certain thresholds where you can say, okay, give blood products, do transfusions. The second thing is, and this is the most important thing we always tell the patients, the white cells will go down. They have neutropenia. But we know when that occurs. So usually neutropenia after such protocol occurs around day 7, day 10. So this is the most vulnerable time. And then it will recover. And to shorten that time of neutropenia and also to reduce the risk for neutropenic fever and infection is we give GCFFs. So it's a stimulating factor. granulocyte convoluted stimulating factor, GCSF. And these are the prophylactic measures we give. Sometimes, not in the Hodgkin protocols, but sometimes you can also give prophylactic antibiotics. But if you do that, you have a higher risk for developing resistant bacteria. Yeah? So we don't do it that often. The most important thing is that you control the patient tightly. Yeah, so you give the treatment, and probably you see them weekly for blood tests. They don't need to be an inpatient. You can do it in an outpatient setting. And if you see it goes into the wrong direction, sometimes you have to admit them because they have an infection, and you have to give antibiotics. Yeah? But this is seldomly the case. Most patients, even if you treat them with Bayer-Corp escalated, young patients, they don't have so many complications. Yeah? And here we come to your second question: can you predict? Yeah, based on certain characteristics, whether a patient is more likely to develop side effects. Yes, you can. We do not use risk prediction models in the clinic, but of course, if a patient has a longer history of immunosuppression, for example, for other reasons, if the patient is old, if you have comorbidities, if you have diabetes, then of course the risk is higher for side effects. Still, if we are in a, say, curative setting, that means we want to treat you for cure, we want to cure you from the lymphoma, we know about the risks, but we probably in the first instance won't change, for example, the dosage of the chemotherapy. Yeah? Because we believe in a strategy that is called like hit hard and early. So if you want to get it, do it now. Yeah. Of course, if the side effects are on the way, for example, the patient has been admitted with severe pneumonia and needs antibiotics for 2 weeks, and probably he went to ICU, of course, then afterwards you have to think, okay, we need to reduce the dose. We cannot do it at the same time. Yeah. So, yeah, dose reductions, prophylactic measures, tight monitoring of the patient, these are the things we need to do. And then it's really a clinical experience and how you do it. Yeah. Sometimes it depends on the health setting and depends on the type of lymphoma. When you really do aggressive treatments, then sometimes I know colleagues, they admit the patient during the time of the neutropenia for 5 days until they recover, and then they discharge them. Yeah, but usually we do it in our outpatient setting. Does that answer the questions?
Very clearly. Thank you, doctor.
Okay, thank you. Thank you very much, Raka. And yes, I think we have already come to the end of the session, I think. Thank you very much, Dr. Kasenda, for a very interesting lecture and also discussion. It's very insightful, and I wish, especially for medical students, you can take the important notes, yeah, from this lecture and yeah, become a good doctor later on. and Dr. Kasenda, thank you very, very much. I really hope we will have other opportunity like this in the next future.
Thank you very much. It was a pleasure.
Okay.
Thank you very much. And very interesting discussions.
Yes, thank you very much.
All the best for you.
Yes, for you too. We are very grateful. Thank you very much. So, Dr. Wilson, I will pass over the baton for you.
Okay. Thank you, Dr. Iren.
Yes.
Thank you, Dr. Benjamin Kasenda, for give us knowledge updates about lymphoma. The next, I would like to invite Professor Paul as our Dean to give a symbolic handover of certificate to the speaker. Please, IT team can help Dr. Benjamin and Professor Paul in the screen and share the certificate on the screen. Take a photo together for the documentation.
Okay. This is the end of the story. Yeah, this is Eko. On behalf of our Faculty of Medicine, Vidya Mandala Surabaya Catholic University, I would like to express I'm very happy to hear your lecture, nice lecture, and address your, thank you very much for your lecture. And also to our participant is very active. I think it's a very important thing that we can discuss with you and far, far away from Indonesia. Yeah. This is a little token, our appreciation for you from our medical school, Dr. Benjamin Kasenda. Maybe next time we meet again and invite you as a guest lecturer. It's very, very valuable, your lecture. Thank you very much.
Thank you very much. I
Receive
didn't
this
expect that.
appreciation. Yeah.
It was pleasure. It was really nice. Thank you very much.
Okay, we make photo together. Dr. Wilson.
Okay.
Okay.
Thank you, Professor Paul and Dr. Benjamin. With due respect, finally, we are now in the final session of this event, the fourth essential learning. It's been an honor for me being with all of you today. Thank you for taking part in this event. Maybe before we end this session, we can eternalize this evening by taking picture together virtually. So can I ask all attendants to activate the video feature and use the virtual background? If you don't have the virtual background, I already sent it in the Zoom chat.
Kita ada 2 punya.
Maybe we wait for the participant to activate the video feature. And I want to ask the IT team for taking the picture.
Selamat malam. Izin untuk mengambil foto. Untuk halaman pertama 1, 2, 3. Untuk halaman kedua 1, 2, 3. Untuk halaman ketiga 1, 2, 3. Halaman 4 1, 2, 3. Halaman 5 1, 2, 3. Halaman 6. Untuk yang terakhir sudah Dr. Wilson.
Okay,
Sudah Dr. Wilson.
thank you, Doctor. Thank you, IT team. And the attendants can fill the attendance form in G-form link in the Zoom chat. Please, IT team can send it to the Zoom chat. And I would like to express my gratitude to the speaker today. Thank you very much, Dr. Benjamin Kasenda, and to fellow students, seniors, and all attendants of the Essential Learning today for your participation in this event. Thank you and see you in the future event in the 5th Essential Learning with Dr. Claudia Hochmann from Germany. Good evening and Salam Widya Mandala.
Thank you.
All right. Thank you.
Dr. Benjamin, thank you very much.
Thank you very much,
Bye-bye.
Dr. Benjamin.
Bye-bye.
Well,
Yes. Untuk para mahasiswa ya, ini baik sekali loh hari ini. Diskusinya maupun ini bisa diambil hal-hal yang positif ya. Ini karena semua full dalam bahasa Inggris dan kita bisa melihat bagaimana karier seorang dokter kelak nanti ya. Tidak harus menjadi seorang spesialis yang bekerja di klinik, tapi juga di laboratoris seperti Dr. Kasenda. Wah, luar biasa ya. Hari ini luar biasa diskusinya. Kebetulan juga mungkin saya juga memancingnya begitu ya. Agak sulit pertanyaannya, tapi tidak apa-apa. Terima kasih Dr. Kasenda dan anak-anak semua, para mahasiswa, para dosen. Juga mungkin juga ada mahasiswa dari fakultas kedokteran lain. Saya tidak tahu, tapi ya terima kasih atas semuanya. Salam sehat dan Tuhan berkati pelayanan kita masing-masing.
Ya,
Terima kasih.
terima kasih.
Terima kasih, Prof.
Terima kasih, Prof.